Osteoarthritis, sometimes called degenerative joint disease, is a non-inflammatory degenerative disorder of the joints. It is the most common form of joint disease. Osteoarthritis can be classified as either primary, also called idiopathic, when there is no prior event or disease related to its development, or secondary, which results from a previous joint injury or inflammatory disease. Unlike autoimmune conditions, primary osteoarthritis does not involve autoimmunity or systemic inflammation. It is limited to the affected joints with no systemic symptoms. Osteoarthritis often begins in the third decade of life and peaks between the fifth and sixth decades. By the age of 40, nearly 90% of the population has degenerative joint changes in their weight-bearing joints, even though clinical symptoms may be absent. Women, especially Hispanic and African American women, are more frequently affected. By the age of 65, over 85% of the general population shows radiographic changes consistent with osteoarthritis. Although it is commonly considered a disease of aging, younger patients can also be affected, and this often leads to significant loss of work-related productivity. To understand the pathophysiology, remember that each joint is made up of subchondral bone covered by articular cartilage. This cartilage provides a smooth surface that protects the bone from damage and allows for fluid movement. Synovial fluid within the joint further lubricates and cushions movement. In osteoarthritis, this articular cartilage breaks down. Damage extends to the underlying bone, and osteophytes, or bone spurs, form and protrude into the joint space. This narrows the joint space, decreases joint movement, and leads to progressive degeneration. Risk factors include older age, female gender, and obesity. Occupations with heavy labor, certain sports activities, previous injuries, muscle weakness, genetic predisposition, and other diseases can also increase risk. The most important modifiable risk factor is obesity. Both quality and length of life are reduced when obesity and osteoarthritis are combined. A program of diet and exercise can reduce symptoms and slow progression. The main clinical manifestations are pain, stiffness, and functional impairment. Pain is usually aggravated by activity and relieved by rest. If morning stiffness is present, it typically lasts less than 30 minutes. The onset is gradual and progresses over years. On physical examination, affected joints may appear enlarged and have a reduced range of motion. Osteoarthritis commonly affects the hips, knees, and spine, but the small joints of the fingers can also be involved, leading to Heberden's nodes at the distal joints and Bouchard's nodes at the proximal joints. Crepitus, or a crackling sensation, may be felt, especially at the knee. Joint diffusion is usually mild, and systemic symptoms are absent. Blood tests and joint fluid analysis are not usually helpful in diagnosing osteoarthritis, but they may be ordered to rule out autoimmune disease, such as rheumatoid arthritis. X-rays may show narrowing of the joint space, bone spurs, and thickened subchondral bone. The goals of management are to reduce pain and stiffness and to maintain or improve joint mobility. Exercise, including aerobic activity and strength training, is proven to decrease symptoms and slow progression. Weight loss also decreases strain on the joints. Physical and occupational therapy can help patients adopt self-management strategies. Orthotics, braces, splints, and walking aids can provide support, decrease stress on joints, and improve mobility. Complementary therapies are frequently used, such as massage, yoga, acupuncture, acupressure, tai chi, and electrical nerve stimulation. Some patients also try herbal or dietary supplements, copper bracelets, or magnets. Research has not consistently shown these therapies to be superior to standard care, but they may be considered if they increase comfort and function without interfering with medical treatment. Pharmacologic therapy is directed at controlling pain and symptoms. The first-line medication is acetaminophen. If symptoms persist, non-steroidal anti-inflammatory drugs or COX-2 enzyme inhibitors may be prescribed, though COX-2 inhibitors must be used with caution due to cardiovascular risk. Tramadol, short-term opioids, or intra-articular corticosteroids may be considered for more severe cases. Topical agents such as capsaicin, methyl salicylate, and diclofenac gel may provide additional relief. Other medications, such as methotrexate or colchicine, are sometimes considered in patients who do not respond to other therapies because of overlapping mechanisms with other arthritic conditions. Glucosamine and chondroitin have been studied but have not consistently shown benefit. Viscosupplementation with hyaluronate injections has been used to supplement synovial fluid, though evidence for its effectiveness is limited. Nursing management focuses on pain control, promoting functional ability, and patient education. Patients need to understand their disease process and the importance of lifestyle changes such as exercise, weight management, and proper use of assistive devices. Encouraging daily activity, using canes or braces when needed, and planning exercise when pain is least severe are important nursing interventions. Pain control is vital for participation in activity and maintaining quality of life. Open discussion about complementary therapies can also support safe and individualized care. Osteoarthritis is a chronic and progressive disorder, but with proper management, patients can maintain function, decrease pain, and improve quality of life.